I will go ahead and introduce our speakers now. Dr. Akpunonu earned his medical degree from the University of Toledo College of Medicine and completed his emergency medicine residency at the University of Kansas Hospital. He went on to complete a fellowship in medical toxicology at Oregon Health and Science University in Portland. Currently, he is an assistant professor of emergency medicine at the University of Kentucky and is the medical director of the Kentucky Poison Control Center. In addition to his teaching and clinical responsibilities, he is interested in medical toxicology and further research opportunities to explore opioid use treatment options. Dr. Regan Baum, originally from Oregon, Dr. Baum received her Doctor of Pharmacy degree from the University of Kentucky College of Pharmacy and subsequently completed a pharmacy practice and in emergency medicine specialty residency at the University of Kentucky Healthcare. Dr. Baum's current responsibilities include providing comprehensive pharmaceutical care to patients in the emergency department. She is also active in precepting pharmacy residents, pharmacy students, and emergency medicine residents and interdisciplinary students while on rotation in the emergency department. Areas of interest include toxicology, infectious disease, resuscitation and teaching. Dr. Baum co-coordinates the clinical toxicology and community emergency response team elective in the PharmD curriculum and is a non-physician teaching faculty for the Department of Emergency Medicine. Dr. Jordan Kelsch received her Doctor of Pharmacy and Masters of Public Health degrees from the University of Kentucky College of Pharmacy and the College of Public Health. She completed a pharmacy practice emergency medicine residency at UK Healthcare. Dr. Kelsch is currently an academic detailing pharmacist with the treatment team in the Healing Community Study. Welcome back to our speakers.
Hi, everyone. Thank you for joining us today. And so for the speakers, we have no financial disclosures. Our practice gaps and educational needs. In recent years, there's been an increase in the use and subsequent harm from synthetic substances that are available in head shops and online. And awareness of these substances and their effects is important to promote the health and safety of people who use drugs. Our learning objectives are for you to identify various substances that are available through head shops and online, to describe the clinical effects of the substances, and to discuss the availability and legality of the substances. Our expected outcomes for you are to be able to recognize the concerns with the use of these substances and to integrate knowledge of the substances into caring for people who use drugs. So we'll go through some basics of our presentation from last week. This will just be summarizing the high points of each of the topics that we covered. So starting with a little bit of background context, we discussed last week the prevalence of co-use in people who have opioid use disorder and who use opioids. In the context of the opioid epidemic, there's also been a rise in the use of novel psychoactive substances. So these are different substances that can be synthetic or derived from plant material, and they're really meant and manufactured in ways that mimic the effects of common illicitly known substances, but they're really meant to evade restriction from a legal standpoint. So often these substances are marketed as legal highs, research chemicals, and they may be labeled as not for human consumption or specimens for microscopy. So unfortunately, there's very little data that's known about a lot of the substances that are out there, and they're difficult to test, mainly because many of the substances have different profiles and contain different compounds. And unlike approved drugs, they're not tested for safety, efficacy, or purity. So just included an example on the right there. In the top left, that compound is mephedrone. You can see its chemical structure is very similar to some common substances that you may be familiar with, such as ecstasy or methamphetamine. Right, next slide. Revisiting the e-cigarette and vape topic. So we discussed all the different type of products and devices that are on the market. And one of the things that we discussed was the type or all the different substances that can be used in the different devices. And so these different substances can be manipulated in different ratios to create different effects. So commonly you'll find e-liquids, and the most common substance that would be found in an e-liquid is nicotine, but there's a wide variety of substances that can be used in vape devices outside of nicotine. So some of those things include THC or CBD, and the flavoring, excuse me, the flavoring and the humectants or solvents that I have listed there. So those are things that help the person that's using the device create the experience they want to. So relating to taste or the type of plume that's created when the device is used. So even these things that are not maybe the main ingredients per se in what someone is using can have a profound effect on the profile of what's being used. So other common substances used in e-cigarette or vape devices include marijuana. So this can be in different forms. This can be in the form of waxes or oils, and that can be used directly on the heating elements. And you can also include or use other substances, including synthetic cannabinoids, methamphetamines, and there's also different chemicals and substances that may be included in these different products that the person using the vape device may not be aware of. The next slide. When looking at overall the safety profile of e-cigarette and vape device products, there's just a lot of unknowns right now. So these chemicals that I have listed here are some of the chemicals that have been found in either the devices themselves, the substances, or the different types of chemical reactions that happen when the substances are heated to high temperatures. So we discussed last week one of the most prevalent adverse effects from e-cigarettes and vape devices that was commonly covered in the media in the last few years was a condition called e-cigarette or vaping product induced lung injury, or EVALI. We discussed how that can cause significant respiratory, gastrointestinal, and different types of effects that require very advanced medical care. And when investigating this, the CDC found a chemical called vitamin E acetate in a lot of the products from patients who had experienced EVALI by testing the different products and even getting samples from different lung tissues and biopsies from patients that had experienced EVALI. So vitamin E acetate was thought to be included in THC oils as a cutting compound, but it's often not disclosed to the user that it's present. So there's a lot of unknowns, and it's really hard to complete research on e-cigarette and vape products. Next slide. So in conclusion, as I mentioned, doing research on all these different products is really difficult for the reasons we mentioned of the thousands of different devices, all the different substances and the different combinations someone can use. So it's really hard to say what effect is directly coming from which part. For people out there, when you're talking to people who may use vaping devices, what we saw in the EVALI cases were a lot of the vitamin E acetate was found in products that were purchased on black market sources or in other informal sources. So just using caution when obtaining products via those sources. Next slide. All right, different substance kratom. So we discussed how kratom is derived from a plant material originating out of Southeast Asia. It can be smoked, ingested in capsules, or brewed in a tea. And the clinical effects are mostly self-reported from people who use kratom, and they can be very variable. So people who use kratom report improved mood, pain relief, and relief of opioid withdrawal symptoms. So one of the main reasons that people who use kratom report their reasoning for using is because it may help them self-manage their symptoms of opioid withdrawal. We discussed that some of the effects may potentially be dose-related, so lower doses having more of a stimulatory effect and higher doses having that more opioid-like sedating effect. Some of the cases that did require medical attention, things reported include seizures, altered mental status, and lethargy. There's also reports of people who do actually experience withdrawal from kratom after cessation of use, and that includes things such as anxiety, feelings of depression, and similar to opioid withdrawal syndromes. There have been kratom-involved deaths, but many of those deaths did involve the use of other substances at the same time, so it's difficult to say exactly what synergistic effect kratom had in those cases. So kratom as a compound is very complex. It has many different components in it. It has two main psychoactive compounds called mitragynine and 7-hydroxymitragynine, and those are thought to create a lot of the effects that are reported from people who use kratom. So some of those are mapped out here on this graphic. You can see the stimulatory effects, the similar opioid-like effects such as pain relief, but there's also other effects that are unknown because of the different ratios of compounds in the various kratom products. And some of those can have serious adverse effects such as seizures, a condition called rhabdo, where your body and muscle tissue are damaged, and then different cardiac and heart rhythm effects. So in conclusion, when discussing kratom in relation to opioid use disorder, at this point, it's really unknown what role kratom would play because we don't have a lot of data on what that would look like. We do know that kratom does have adverse effects, so there really needs to be more research into investigating what role it could play. Because many of these products are labeled as legal and safe and natural, it's important to know that that does not mean that they are completely safe and without risk or without harm. It's also important to know the risks of combining the use of kratom with other substances. As we saw in many of the Poison Control Center cases, a lot of the more advanced cases that required higher levels of care and treatment were when kratom was used with other substances. And when you, and just when you're speaking with people about their kratom use, I think it's important to discuss why they want to use kratom and if that can be an opportunity to connect them to care. Next slide. I'll hand it over to Dr. Akpunonu now.
So yeah, mine is just on in general dealing with cannabinoids and kind of the receptors that they work at, and recognizing that this is a relatively diverse kind of group of substances and they're ever expanding. Seems like almost on a daily basis. The endocannabinoids are the ones that naturally occur within the brain and the central nervous system. And then, our phytocannabinoids are the new cannabinoids that sometimes we appear to be discovering as we look more and more into the marijuana plant. And the synthetic cannabinoids are the ones that are at least initially created with the purpose of research and stimulating these CB1 and CB2 receptors. Next slide, please. And really what it comes down to is that in dealing with cannabinoids at this point in time, it's difficult to distinguish between them in any sort of hospital laboratory and even likely commercial laboratory. You really need a good research laboratory to distinguish between all the different cannabinoids. Ultimately, in terms of treatment at the bedside, there really is no difference and there's no need to know exactly what someone got into. You can treat them symptomatically because there is no antidote. We just want to make sure that we provide them the best care possible. As time goes on, we're likely going to see more and more cannabinoid exposures as we develop more and more, and as well as we learn to extract more and more from the marijuana plant. Next slide, please. And this one goes to Dr. Baum.
Thank you. So I had the synthetics, synthetics, we lump together the synthetic cathinoids and the synthetic cannabinoids. And the reason why is for several reasons. On the next slide, I'll show you that the clinical presentation is such that it sometimes is hard to distinguish which one is which. They also kind of hit the market and became mainstream at the same time in around 2011. So both of these are novel psychoactive substances. Our synthetic cathinones actually very much are structurally related to amphetamines, whereas our synthetic cannabinoids are lab derived, but they're a very diverse set of chemicals. Just because of the cannabinoid system, it just allows different things to bind to those receptors and cause effects, basically. Next slide. In clinical presentation with these, you can see that there's a lot of overlap in the way that these folks present. So if you remember from the lecture last week, sympathomimetic is really that set of symptoms that would happen if you went out and ran a marathon, or people that use the classic substance here is cocaine, right? That would be sort of the sympathomimetic effects that we might see, in addition to some of the psychosis and hallucinations that we see from some of these substances. So there's a lot of overlap, and sometimes it is really hard from a clinical standpoint to know what we're dealing with. Next slide, please. In conclusion, both of these substances and these structures of these substances are ever changing, and they're ever changing it in a way to sort of elude law enforcement. They're very much mixed clinical pictures. It's really hard for us to know what people took. We don't have a direct antidote, but as Dr. Akpunonu stated earlier, we really are talking about very much symptomatic and supportive care, because confirmatory testing is just very, very difficult at this time. Next slide. Do you want me just to read the questions and keep going, John? Okay, I'm just going to keep going. So for question one of the questions we got was, for the treatment of common substances from Headshops, it sounds difficult because there's a lot of unknowns. How do we determine what someone has used? And, in reality, knowing the definitive substance isn't always necessary for us to be able to treat them. As stated earlier, we treat people a lot based on what their symptoms are, right? And we call it symptomatic and supportive care, and we support them through it, when they present based on what's kind of going on. But we do try to seek a really good patient history to figure out what they got into, and sometimes patients don't always disclose what they took. They're not always the most reliable historians. Sometimes we can ask family or friends. Sometimes they can be reliable, not always. A lot of time, some of our pre-hospital workers like EMS, they sometimes will bring paraphernalia that was on the scene, or tell us what was on the scene that can give us clues. Police, so anything that we can do to kind of attempt to understand, what they took, when they took it, how much they took it. And, however much of that information we get, we take. A lot of times we don't have a lot of it, but, we will rely on things like physical exam and that sort of stuff to sort of determine what sort of care these people need. Because unfortunately right now for a lot of these substances, we don't have confirmatory testing that's readily available. The second question on this slide was with regard to discharge. So what are the tips that we use for talking to patients about these substances at discharge? I think we would all say, please stop using them. We would all preach abstinence, but in reality, that's not always possible for people, and it probably isn't going to happen. So I think a few talking points that I try to make people understand is, when we see people that overdose in our ED right now, almost nobody is overdosing on a single substance. And a lot of people don't even know what substances that they're getting. And the unreliability of that, I think, is important for people to understand what that risk is. But if you can know what products you're using and how much you're using, I think that's important. If you're going to use, if you can do it in a manner that is, I'm going to say safer, right? Don't do it alone. Don't drive a car, things like that can be important. I think, because we are seeing so many mixed exposures right now, harm reduction strategies are very important to offer, making sure that people have access to naloxone kits. If they're using injectable drugs as well, can we plug them in with needle exchange programs? The dose for these things absolutely makes the poison, so when you think about other people that people are around when they're using, small children could have much more profound effects with this. And there was actually a story on WKYT yesterday about somebody that had made some marijuana brownies and their mother had taken them to to like a group gathering of elderly people, right? So, I mean, just being responsible with the stuff that we have in our house and trying to make sure that they're out of reach of children, I think is really, really important.
So I will add, it doesn't necessarily have to be a part of the discharge process here, but depending upon your role, being able to establish appropriate rapport with your patient. And if you can, to really get to somewhat try to ask, why is it that you're using the substance? Oftentimes that's something that we forget, and that simply being able to answer why may lead us to better outcomes in terms of treatment or better plans for them. Are you using this because what you actually have is concomitant depression or something like that, or are you using this because you're no longer able to get to opioids, or are you using this just because it feels good? That really opens up the discussion and a plan of action to move forward.
And we can move on to the next one whenever you all want, unless Jordan, you want to roll in there.
I'm just going to open it up to our audience and ask if anyone had any thoughts on this.
You guys mentioned sort of the dose makes the poison, but do most folks know what dose they're actually getting in these substances?
No, right? And stuff isn't always marked. I think that's the other problem, right? For a lot of these substances, they're not marked for human consumption. They're not really regulated by any sort of body that says that you have to have accurate info on the package, right? So no. I mean, I think that's part of the risk that we really do have to kind of make sure that people understand when they engage in these behaviors.
Unfortunately, the good old days of being able to trust your dealer are kind of gone. Time was your dealer at least knew what they were giving you. And I think to this point now, I'm not even certain that the folks that are dealing or selling to you know entirely what they are getting. So being able to appropriately titrate your dose, it just doesn't really happen. It just doesn't occur in the same, let's say, safe manner that we have seen in prior years.
Excellent. It looks like there's a question in the chat, but I think that is going to relate to a question upcoming. So we'll hold the one question I just quickly had is, do you tend to see trends with certain substances, or does it tend to be variable? So do you kind of get in not like a rhythm, but there's like a week or a couple weeks where it's like, wow, we're seeing a lot of X or a lot of Y?
So yes and no. We don't see a lot of variable trends in that, this month everyone is using heroin and the next month everyone is using cocaine. In that regard, we don't see those kind of our prototypical drugs that we've always learned about and talked about as often anymore. We do see trends in emerging novel psychoactive substances. So new cathinones, new cannabinoids, new substituted opioids will appear. And so even new benzodiazepines now are common as well. To see them appear on the scene and be present for a couple of weeks and then disappear as something else comes along, you can see, if you look back on the things dealing with like the synthetic cannabinoids, you would see like ADB Chimanaka show up and be present for a month and then disappear, and then AB Fibonacci would show up and then disappear, and another one would show up and disappear. Effectively, as law enforcement catches up with the idea of, if we have to schedule each one of these substances, we can slowly make that one illegal. And as the process of actually clandestine manufacturing begins to improve, you'll see changes in time. But synthetic cannabinoids are still around to carry around, and speaking to some of our patients, they like to say, well, the only thing that I use around here is Serenity. And the problem is you don't know what you're getting when you're getting Serenity. You're getting whatever substituted cannabinoid on any given day.
And a lot of those patients that endorse Serenity, the other trend that I will say we are kind of seeing, and I think is probably not going anywhere, is that a lot of these people that come in saying, I use Serenity, or I use heroin, or I use cocaine, they're testing positive for somewhere probably between 3 and 7 other substances, right? So, I can't remember the last time I saw one of these drug screens light up and it was just one thing. So, there's a lot, I think people don't know what they're getting. All right, so this question is really asking about the value of testing for some of these substances when we don't necessarily have them back when they're in the hospital. And, traditionally this has been sort of one of the arguments, right? Like, Do we need a test if we know that it's not going to come back and we're just going to use symptomatic and supportive care? These tests are time consuming, they're expensive. You know, the drug use patterns in the community change really rapidly. And a lot of times our drug panels really test for more past or historical things. They don't necessarily keep up with what's out there. I think we sort of feel like there's probably an epidemiologic purpose that we think is important, and we think it's important to try to tease out when we think there are novel things there, and we are trying to do that here at UK. I think, you know, it would be nice if we had some stuff that came back a little bit faster. Some of our immunoassays are a little bit faster. It can tell us when we have other substances there that maybe the patient didn't endorse. So, you know, if somebody says, I use Serenity, but they pop positive for an opioid, can we make sure that we engage them in some of those harm reduction strategies earlier, which I think can be important. Although I will say we're doing that without the testing being back now for sure. You know, urine drug tests can also provide us with a lot of information about, you know, especially if patients are admitted, about other stuff that patients took that could be complicating care, right? So are there exposures to other medications? Could they potentially have implications on their other medical conditions? So we do think that there is probably some utility to this. And I know Peter and Jordan will probably have some insight too.
So the simple answer, which is not so simple, is yes and no. Wearing the emergency medicine hat for my primary practice, getting the results of drug testing is not particularly helpful. By the time that result has come back, hopefully I have already treated the patient and have an idea in terms of what they have gotten into, what their substance use has been. On the flip side, for my colleagues that are impatient for when I'm doing my addiction time, the answer is yes. I do want to know. I want to know what you're actually getting into. I also want to know what you believe you're using. What are you actually using? What do you believe you're using? And where is the discordance from there? And then to top it off with the epidemiology, yes, I want to know exactly what is out there floating around in the community. What is being used? What is being sold? What is it being sold as? So from, again, the emergency department standpoint, maybe not the most useful test that I can do. From the addiction and epidemiology standpoint, yes, this can be incredibly helpful. This can be helpful for me in terms of addressing other substance use, or what is, let's say, unrecognized or unknown substance use that you don't realize that you've been, you know, doing heroin and methamphetamine for years. You've been thinking it's just heroin or it's just meth the entire time.
Yeah, another point I'll add, outside of, I think, the quote unquote active ingredient that someone thinks they might be using, there's so many contaminants and adulterants that can be found in different products. And what Dr. Baum mentioned about last week in some of the spice products that were contaminated with superwarfarin, which is a blood thinner type of medication, and people were presenting with severe bleeding episodes. So even knowing potentially where someone may have been exposed to something like that, even if you do get that information later on, I think that can be helpful in order to educate other people.
Great. Does anybody have any follow-up questions or thoughts about this question?
Okay, we'll start with question 3. So because polysubstance use is common in persons with opioid use disorder, in what ways can using these substances like kratom, synthetics, or vaping products complicate treatment of opioid use disorder? So I think that was one of the ones that was related to the question that was posed in the chat. As care navigators, what substances do we need to be aware of and educate about for our clients who are in MOUD treatment? So I think this is super important, right? And the first thing that I think you can talk to your clients about is why they are using the substance, and try to do a little bit of a deeper dive into what their motivations are for using those substances. Specifically, kratom comes to mind, especially because of its use in self-management of symptoms for opioid use disorder and opioid withdrawal. Potentially, they need to be adjusted on their dose of their MOUD, or they need to get a different type of, change treatment modalities, things like that. I think can open up the conversation with people and just talk to them about what's going on. I think, on another point, it's important. It's really hard to talk about these things because, as for all the reasons we've discussed, it's hard to know what's in them. It's hard to know if, the person that's using them, what they think they are using, but they can have adverse effects. And unfortunately, we don't know a lot specifically what those could be tied to because of the different ratios and compounds that are involved, but we do know there's adverse effects with many of these substances that we've discussed. So just having an open conversation saying, just because they are promoted as not for human consumption or they are legal, so it's safe, there could be risks associated with them, and just having an open conversation about it. From a pharmacist standpoint, I think, when you talk about for someone who is on MOUD and someone that is using another substances, there's always a potential for interactions between the two. Unfortunately, we probably don't know exactly what that could look like, and they're always changing. But when you think about their impact on the medication treatment, you could potentially get higher levels of your buprenorphine or methadone or lower levels, and that could be impacting treatment and causing symptoms that someone may not necessarily attribute specifically just to using another substance.
So
Dr.
for me,
Baum,
this also, oh, sorry, Jordan.
I was going to say, you all jump in. If you want.
I would also add that this can be kind of helpful in trying to assess whether your patient is manifesting treatment failure or not. So, you're using multiple substances. Let's take the example of I'm treating you for OUD and I've got you on buprenorphine, but you're still feeling bad. And I've got you on an appropriate dose of buprenorphine. This may not be that buprenorphine is failing your treatment. You may be experiencing, washout or true withdrawal from your methamphetamine, and that's why you feel bad at this point in time. It's not that we have failed to treat your OUD, but rather there's another substance that's interfering with your treatment as well. Another set of symptoms that are coming up that we didn't realize you had before.
Yeah, and I'll add on to this another point. I think we often you can ask someone what they're using, but also being specific, because someone may not attribute using kratom to using a substance. To them, that could be an herbal supplement. So making sure you're asking about all different types of products to really get all that information.
And I'll say I see this quite frequently with when I ask, do you use any illegal substances? And the answer is no. And then you say, well, do you use marijuana? Yes. And you say, well, I asked you if you used anything illegal. No. Well, marijuana is not illegal. And you're like, okay. It doesn't quite get to the crux of the point, but yes, that, not everything that we would think of as being an illicit substance will be an illicit substance to your patient.
Yeah, so I'm curious if anyone in the audience has had any experience with any of these products, and maybe with their clients, if that's created difficulties in their treatment or recovery.
So I deal with this all the time in the outpatient setting, where we sometimes have to shift our priorities of treatment because of some of this other substance use. So I'll give an example of a gentleman that was treating for benzo use disorder and sort of navigating a prolonged benzo taper. And then he sort of picked up kratom use as we got to lower doses, and it was using at high enough levels that then he was also navigating kratom withdrawal. And so we had to shift and take a pause on sort of the benzo taper and try to address the getting off of the kratom, which was not something that he typically wanted to use, but was dealing with more pain and other issues. The other thing, and to Peter's point, which is a really good one, like when there is use of these other substances, we should think about other things going on in this person's life, right? And trauma and significant mood issues are numbers 1 and 2 that I often see when there's a cessation of sort of opioid use, but ongoing use of some of these other agents to try to mitigate traumatic memories, nightmares, sleep issues, mood issues that are really, really common among folks in early recovery.
Yeah, so I'll read, Chris put in the chat, in previous work as a counselor, would have multiple individuals indicate using substances helped with anxiety or depression with other medication, or when other medications were not. Curious if others have suggestions in those type of situations of hearing the patient and supporting evidence-based care. I think that is really difficult because treating those take a lot of time and a lot of trial and error, and that can be a really trying period for people. So just like you said, you know, confirming their feelings and their experiences, but also trying to offer alternatives and support through the time it takes to work through those things.
To Devin's point, with some of the trauma and the mood disorder, remember that parts of substance use are just a ritual, and the ritual is satisfying, and the ritual alleviates the anxiety. The ritual will help to alleviate some of the symptoms of depression. So, you know, being able to ask and have an idea of what they're using, why they're using it, and, you know, whether that is actually going to be effective in using it can also be something else to address. That their substance use is not solely to get high, but maybe, like you point out, to alleviate the anxiety, alleviate the depression, to avoid their withdrawal. And this helps them get back to normal. It may simply be the ritual that is helping to improve that for them.
Looks like there's one more comment that I can read. A couple of years ago, we had a couple of patients admitted to BHU at GSH who appeared to be impaired and had varied symptoms, but tested negative on UDS and ED. In searching belongings, we found kratom, and the patient was extremely ill from apparent withdrawal symptoms from kratom. We had to do quick research to figure out how to treat them safely.
So yeah, this kind of supports my yes and no argument regarding testing. We sometimes seek comfort in, hey, well, their urine drug screen was negative, so clearly they can't be on something, and that really just means that, you know, either their urine drug testing, they have a substance and it's below the cutoff, so we simply can't detect it. The timing may be off for when we collected that urine, hasn't had time to enter the urine, or something that we simply cannot test for. You know, I think that we're all fairly good at recognizing when someone is intoxicated, what they're intoxicated with and to what degree of intoxication they have, we're not so good at. But you know when someone is at a baseline, or when someone is not at their baseline. And simply just because a drug test tells you that it's negative, that doesn't mean that. They can still very much so be positive and still be using any number of substances that just aren't tested for.
Question 4, how can non-medical professionals talk to others about, quote, legal substances, and are there ways to reduce harm from using these substances? So I think one of the main points to remember is that we just don't have a lot of data about their safety or what's in them. And so even though they're not necessarily illegal, that doesn't mean that they're without harm. And so having that conversation of, you know, someone may feel a blanket of security because it's not necessarily illegal, but that doesn't mean that could not be harm from it. We also don't know for some of these things, you know, what the long-term effects could be. So I think getting into why someone is using something and then trying to help connect them to care to address that would be a good way to go about that. For ways to reduce harm, I think one of the main points that we've highlighted in a lot of these different substances is that the combination of using multiple substances at a time is where your risk is increased for adverse effects. So trying not to use multiple things at the same time. As Dr. Baum mentioned, obviously getting naloxone, having that available when you're using substances, not using them alone, things of that nature. So, do you all have anything that you would like to add, or are there anything that, you know, from your experience in talking to clients, how you would have this conversation?
I think I would just add something about the security of keeping that out of the hands of children that are in the home. You know, we're just starting to see so much with, especially things that are edible, that look good. You know, I can't say that enough, because that really, when we talk about the dose makes the poison, no, we don't know the dose, but they're little tiny bodies. And so it just takes so much less for the exposure to be really significant. And it's just a collateral damage that is happening with this. And it's worrying.
I know we've already touched on this a little bit, but we can talk about it a little bit more maybe.
The simple answer here is yes. Depending upon the amount that you use, The answer is yes, you can experience some withdrawal. The symptoms that you expect to see are those that are the opposite of what occurs when the patient is intoxicated with that substance. If you go dig through the literature and try and dig through some of the books, you may find something that's conflicting in that. I remember as a resident and then as a toxicology fellow, they would refuse to admit that methamphetamine has a withdrawal syndrome. And the polite term was methamphetamine washout. Well, the patient is suffering from methamphetamine washout. Well, what is happening? Well, they look neurotransmitter depleted. They're tired. They're agitated. They don't feel well. They're cranky. And you're going, well, geez, what makes that better? Well, when we give them methamphetamine, it goes away. It gets better. That seems to me a very simple definition of withdrawal. They had the substance is gone. They are not back to baseline with the absence of the substance. They actually feel worse or have an overshoot. So yes, they can have withdrawal from these substances. The management of the withdrawal can be difficult and can be complicated. Some of these are going to have appropriate FDA approved treatments. Others are not. The goal here is to try and manage their symptoms and hopefully not push them towards something that is equally as dangerous or more dangerous than what they're using.
I'll just make the point that some of these substances are being used because there's less perceived withdrawal, right? Or there's less perception that one can become dependent on that substance. And just recalling it back to sort of DSM-5 diagnosis of a substance use disorder, it doesn't require withdrawal. It does require significant impact on those other domains of the person's life that are important: relationships, social, family, job, that sort of thing. So binge use of, say, a cathinone or a derivative or cannabis or other things, even if it's not causing a sort of classic withdrawal syndrome, or it's really only in a binge pattern, can be a substance use disorder that warrants treatment and evaluation. And so these are sometimes perceived as less harmful because of you're not necessarily going to see dependence develop, but a substance use disorders from these substances certainly can develop.
Yes, I'll read it. When working with patients that have polysubstance use, including substances in the presentation, how do you develop a treatment plan? And do you triage certain substances? For me personally, I am one who will tend to focus on, one, whatever they believe that they are using in terms of treatment, and two, if I'm concerned for someone that's going to have or develop withdrawal, which is going to be their life-threatening withdrawal. And I'm going to use that term life-threatening withdrawal probably a little bit more loosely than people do. My traditional med school education was, alcohol, benzo, and barbiturate withdrawal are lethal withdrawal syndromes, and that is what is going to kill you. And that is correct, in part true that the absence of that substance does increase your risk of death. But I would always argue that opioid withdrawal is a lethal withdrawal. And it may not necessarily be that you're going to have the physiologic effect that is going to kill you directly, but it is a physiologic effect that's going to drive you to take greater risks and take riskier decisions in terms of further substance use that can ultimately wind up ending your life. So for me personally, I don't necessarily know that it is best, so I cannot say that this is the way to go. But if you are a benzo and opioid withdrawal, I'm immediately more concerned with your benzo withdrawal because I don't want you to die at any acute time frame. That does not mean that I'm going to ignore your opioid use disorder, your opioid withdrawal as well, because that also is going to, I know, carry with you a long-term use, a long-term risk, and can cause you to take part in some other behaviors that are going to put your life at risk. To be entirely honest, when it comes to this, I usually call my friend Devin and ask him.
To which I would say, Peter, I trust your judgment. But I agree that that component of threat to one's life is probably most important. But understanding the patient's priorities as well. Like I was mentioned with my other case, it was a gentleman who really wanted to get off of all benzos, and we were working on that. But when the kratom withdrawal sort of kicked in, that became sort of the most urgent thing, because he was worried about a slip back to the benzos that he was using before. So if there is multiple substances going on and we're following the patient or the client in the outpatient setting, for our audience here, your first impulse should be increase that frequency that you're touching base with the individual. Because as you accrue more and more substances going into the system, it's just more complex, and you need more touch points to make sure that you're understanding that the patient's priorities are aligning with the treater's priorities, and that you're moving things forward in the positive direction.
I can read it. So what is CBD oil gummies, and do these substances have any benefits or adverse effects?
So in theory, your CBD product should be a non-THC, a non-Delta 9, Delta 8 THC product. So that you should, in theory, be able to feel better without the intoxicating high. Do they have any benefits? I don't know. Every day we're studying something new. I remember, back in Oregon, we were still studying CBD for the treatment of epilepsy and Lennox-Gastaut syndrome. And we're still doing more and more trials. To say that there's no benefit, if I said for someone to say that, would be a lie. To say, do they have adverse effects? The answer is yes. I've seen adverse effects, we know. And, to the great toxicologist Paracelsus' statement, the dose makes the poison. So what may be beneficial at low dose will be toxic at high dose. Will these substances show up on the drug screen, on your typical immunoassay drug screen? No. If you have a more advanced lab, something like the ones that we see at UK U of L state labs, they can. They typically do not specify what type of CBD, what substituted CBD. They may just tell you that it's blanket term cannabinoids, without real definition as to what's going on. And honestly, at this point, there's not a whole lot of reason for it to be more specific, as we don't identify toxidrome, we don't identify a specific treatment for any one type of cannabinoid product versus another.
Thank you. I think that makes sense. Yeah, it's just on TV, it's just all positive effects. It's all, herbal and natural, and you're going to feel better. And it's, every gas station has the signs and things like that. And it's just curious what that is. So thank you for that.
I mean, it's genius marketing, right? Like you'd never think to use heroin if the only advertisement was for how bad the withdrawal was going to be when he didn't have it. Like you'd never touch it. You wouldn't buy Coca-Cola if it was like, this is entirely artificial and is absolutely terrible for your health. No, the advertisement is, hey, it tastes good, so use it.
Fair enough. All right, let's see here. I believe Regan, Dr. Baum had this.
Yeah, I did.
Slide.
Yeah, I thought this was just interesting and very timely. This actually was picked up by our local news yesterday, WKYT, talking about the research that was happening at OHSU regarding regarding cannabinoid compounds. So basically what they did is they went and they looked at the way, so for coronavirus to be taken into cells, it uses a spike protein. So this interferes with the spike protein. So this was published in the Journal of Natural Products yesterday. Now, what I will say is, and the reason why I wanted to share this is, anytime these things have come out, and this has very much been CHOP research, probably done in a test tube, right? This is not done in a human environment or in human subjects at all. But anytime this type of research comes out, what we see is a spike in uptake of the products that are associated with the research. And so, it will be interesting to see if in the weeks to come, if we see more people trying to purchase some of our CBD and our cannabinoid products that are available in the Headshop. So I just thought it was a very timely thing that hit my Facebook feed yesterday. So it's kind of interesting.